Hey guys, welcome back to the FOAMfrat podcast. Tyler and Sam, and we got a really cool episode that was actually part of a class I did on return of spontaneous circulation inside studio. So I wanted to bring on Leon Eydelman, Dr. Leon Eydelman. He's a member of the FOAMfrat team, ECMO guru, intensivist, and I wanted to ask him how his ROSC therapy and treatment has changed since the targeted temperature management 1 and 2, the TTM1 and TTM2, and really just get a pulse on what he's doing in the ICU and maybe some things we can improve on in the pre-hospital setting. So Sam, you listened to the episode. What'd you think?
You guys covered all the bases. That was a really good refresher on all that stuff, from sedation agents to should you paralyze to basically the logistics of how you measure that stuff. And I don't want to get too much into what you guys talked about because it's a really good discussion, and I appreciated the shout out at the end about we'll have to have Leon back on for the glucose discussion, because he was somebody I was going back and forth with on the phone when I was writing that, and I'm like, dude, am I crazy or is this like legit? But no, one thing that I was thinking about when I was listening to that was you guys were talking about kind of the inaccuracies of certain monitoring devices. And so if you just have like a tympanic measurement, like, can you trust that? And somebody's whose like perfusion is horrible, or you take a tympanic, or you try to, I don't know, you shove the oral thermometer next to the ET tube or something. It's like, can you trust that stuff? And it kept reminding me of end-tidal CO2, where it's like, obviously you don't want these patients to become febrile, and you guys go through all the different measurements of like, what should you aim for versus is it better just to like aim to keep them out of a fever. And I was thinking about how somebody could definitely take one of those thermometers, non-invasive, like non-core temp, and they could look at that and be convinced that maybe it's not high. And it reminded me of end-tidal CO2. I thought it was super analogous, where it's really dangerous to treat a low end-tidal CO2 unless you know what the PCO2 is. Because you can have a VQ mismatch, and it's like, yeah, your end-tidal CO2 could be 20, and if you had a really bad VQ mismatch, maybe the PCO2 is 100 or something ridiculous. Yeah. And I was thinking, that's a lot like a non-core temp versus a core temp, where you can check the skin, maybe it's really cold, and you're convinced that this patient doesn't have a fever or anything, but then somebody drops an esophageal probe, or they have a probe attached to the Foley, or they have that Arctic Sun that you guys were talking about as well, which integrates with that stuff. And you could be totally tricked and maybe even report that to the hospital. And so I was thinking about how if you wanted to err on the side of caution, I mean, for sure, use those devices, because if it's high, it's definitely high. Like if it's making it all the way to the skin and you check that and it says that they're febrile and it's 36, 37, whatever, it's for sure. Like you're not getting that temperature reading from nowhere unless you can account for some type of environmental issue around you, which everybody should be aware of because everybody will probably be sweating. But if it's low, you can't trust that too much,
Yeah, a low temperature. I mean, I've had patients that are, they're in the ambulance, they're running a fever, and because they're, you walk from the house to the ambulance, you feel their head, it feels cool, and then you feel their body and they're burning up. So there is a lot of variance when you're looking at peripheral versus core temperatures. And if you let them start running a fever, the survival with good neurological outcome, all of that stuff starts to drastically drop down. So yeah, that's something to really pay attention to and try to get a core temperature. And I think temperature management and, whether that be a trauma or whether that be not letting somebody run a fever is probably something that EMS is historically bad at. And I think it comes down to
both ways,
the way we actually measure it.
Yeah, both ways. Keeping patients warm if it's a trauma, and then probably keeping patients cool if it's something like a cardiac, post-cardiac arrest scenario. And I think just to preface the podcast on why this would be important, it's decreasing metabolic rates. I read a paper just a little bit ago, because I couldn't remember the percent, is like 5 to 7% or something like that for decreasing the metabolic rate, which obviously if the body's not perfusing well, you want to lower those metabolic requirements, obviously keeping them from shivering and things like that, because that really raises your metabolic requirement. And then the paper was also talking about reperfusion injury and then secondary brain injury as well. So it's serious stuff, because what else are you looking for after cardiac arrest? It's like they have ROSC, the heart is at least pumping, and now the other part is is the brain ever going to come back around and this patient has a good neurologically intact survival? So great episode, and I will have to have Leon back on to talk about that glucose stuff too.
Yeah, absolutely. All right, here it goes. Here's what I wanted to pick your brain on, because right now I am re-recording the ROSC section inside Studio.
Okay.
And so I'm updating it, and there's not a ton of stuff that's like groundbreaking with it, right? You want to keep the vitals good, keep the blood pressure up, the oxygenation. But we didn't really hit on, in the last one, targeted temperature management. And it's kind of swung back and forth. And I've looked at the recent evidence, and it basically looks like, hey, just don't let them run a fever. That's the main thing. Is like, as soon as you run a fever, you start seeing that the neural outcomes and stuff start to go down. And so you don't want them to get above, I don't know, what is it, like 37.7. You don't want them running a fever, but are you actively cooling? And if so, are you saying, hey, you know what, 36 is probably just as good as 32 degrees Celsius? And so without even looking at like the evidence, or maybe you're utilizing that current evidence, like what is your practice? You got somebody who was down in the ER, they went into cardiac arrest, they got them back, they're intubated, they're not really following commands or anything. We'll say they're like comatose. They come up to your ICU. What does the care look like as far as targeted temperature management?
Yeah, I think you're right that it's swung quite a bit in the last, since I was a resident up to now. I think a lot of things have started to look a little more nihilistic, but this is definitely one of them. So at this point, and really a lot of what we're doing now, like Target TTM2 came out, I think 2021, and that kind of was a study that didn't suggest too much benefit in aggressive cooling, and I think that kind of was the last straw for a lot of people. So we pretty much never will cool to 33, like 32 to 34 is a very rare event. And logistically, it's a lot harder to do now. We have all these order sets, all this stuff that was built for it with these like crazy every 6-hour labs, and it's like super resource intensive. So, years ago this was built, and this stuff takes 5 years behind the literature. So at this point, it's like difficult to do that. If you really want to cool to that degree, it's a whole to do. It's incredibly resource intensive. It's very rigorous and algorithmic. And I'd say most of my colleagues never do it. I have a bit of a sweet spot for like a young VFib, VTAC patient who's otherwise hemodynamically stable and who I know the family's gonna like go the distance for no matter what. That might be a patient that I'm still considering 33 degrees, but it's rare for me, and I'm one of the few I think that still thinks there might be some benefit to it, and I think that's really where the current trajectory is it's just that 33 degrees thing might not really be relevant for the all-comer out of hospital arrest population. We're pretty routinely doing 36 degrees. That comes from TTM like one, the first TTM study of 36 versus 33, and that's a lot less resource intensive. I think you can question at this point if there's really even any evidence that 36 is better, but avoiding fever, I think, is still 100% everyone's main objective here, and that's what TTM2 looked at. It was, I think, 37.7 was their definition of fever. So we definitely don't want that, but it's just logistically speaking, if someone's on an Arctic sun or I've assigned them to be targeted temperature treatment, it is a lot different from the nursing perspective. They're checking temps more frequently, so you're far more likely to catch an actual temperature that way. And so even if maybe I'd be okay if someone could promise me 37 degrees, I don't get those promises. If I ask for 36, I get active temperature management. I got a nurse who's really thinking about that, and I've got a lot more ease with addressing fevers. And the Foley goes in because we need to keep control of the temperature, versus if I'm not asking for that, then it's, oh, well, we don't need a Foley. We're trying to minimize our CAUTIs and stuff like that.
Yeah, that brings up a really good point, because when you're in the ICU and you're deciding you're going to target a specific temperature, you mentioned the Arctic sun, and I've never actually used one of those, but from what I understand, it is in real time adjusting the cooling based off of the bladder temperature probe, trying to keep them at a certain number. Is that correct?
Yeah, it's really cool. It gives you a gauge too of, we struggle with, is someone trying to have a fever when their temp is controlled? So some places will do, daily or every other day blood cultures. Like there's a downside to not knowing what the temp is trying to be. So the Arctic sun is neat in that you can see how cold the water is getting. So like how much effort is being used to cool the patient, which is a surrogate for how hyperthermic they're trying to be. So yeah, based off the water temp, man, this guy's, water temp is like 10 degrees Celsius. It's really working hard. Maybe we look into empiric antibiotics, getting blood cultures, or is this person seasoned? Is there like subclinical status? So it adds another tool that maybe isn't really, oh, it's the temperature I'm trying to control so much as I get this device and I get more intel from it.
And some people may ask, well, why would somebody start running a fever after being resuscitated, after cardiac arrest? And in this class, I talk a little bit about the translocation of bacteria during an ischemic period that can happen within the gut. Or I mean, purely they could have aspirated or something. Are those like the main causes? Or is there just like the systemic inflammatory response that you see after an arrest that people tend to get?
Yeah, I think you definitely get some degree of like a vasodilatory, almost like a post cardiac bypass type of hyperthermia. Sometimes you can definitely see that. You can also get those from direct neuro injury. So we start to see fevers from actual neuronal injury, and we know that can feed back to itself. And that's kind of the baseline part of it. You're absolutely right about then making sure things don't get worse with fevers, with like infectious stuff. I think it's become a little more common to use antibiotics empirically at this point. I wouldn't say that's everywhere all the time, but especially what you're alluding to, the gut translocation is a decent rate of like serial surveillance blood culture positivity from anaerobic things that live in the gut. So that's one of the things that we can actually control for. The other thing is these subclinical seizures. I mean, if you do have a bad neural injury, could that have precipitated an epileptic focus? And now some of what we're seeing isn't anoxic brain injury, but ongoing status that's non-convulsive. You'll definitely get a fever with that, and that becomes really important because someone who's young or otherwise viable, if you can get control of that, perhaps you're really changing the outcome here. Versus the other stuff, some of the neurostorming and the post-arrest kind of hyperthermia is baseline stuff. And then shivering, of course, if that is going to happen from what you were doing, is going to play a role in that temperature too.
Yeah, so I want you to take off your ICU hat once, and I want you to imagine you and I are we're transporting a patient from hospital A to hospital B that got resuscitated. They were in cardiac arrest, couple shocks, VFib arrest or whatever, and we're like taking them to another hospital to get PCI. Maybe the EMS just took them to the local hospital. So we're in that transport now, and I take my little temperature probe thing and I scan their forehead, and it comes up and it says that their temp is, let's just say it's 98.6 or 98.7 or something like that. How much do you actually believe that in terms of like just the temporal scanners? That's where I want to start this. How reliable is that? Could they still be running a fever, but the ambient temperature of the ambulance, the helicopter is just not allowing you to pick that up?
I think categorically, yeah. We always use, putting my ICU hat back on, we always use two temperature sources. So it's a Foley and an esophageal one because we really want to be sure about that. And I think, those temporal scanners are good enough for the most part, but there's clearly benefit to fever control. So my thought would be, if there's any question of doubting what your temperature is, if you have interventions that are low risk to bring the temperature down, it probably behooves us to do that. Because I'm not sure that I would buy, something that's just an external temp monitor to make a decision about something as important as that.
Yeah, I mean, you think about the logistics in the ICU of the Arctic sun and adjusting the temperature, and you have an esophageal probe, and you have the bladder one, and you're looking at two different sources compared to somebody just scanning their head and being like, oh nope, it says they're fine. Because I've seen where you feel the patient's body when you're putting on the 12 lead stickers and it's super warm. And then you feel their head and it's like, it's kind of cool. And you're like, okay, like if I scan their body, it's showing me that they're running a temp. And so I think the reliability of these temperature probes in EMS is historically just not that good. Where I fly at LifeLink 3, we have an esophageal temp probe. It's esophageal or rectal that we can use. And that I seem to trust that a little bit more, obviously. And when we're given like product and stuff, we're constantly monitoring temperature to look for like a reaction.
Sure.
But I feel like if you are getting a temperature on your temporal probe, there's a good chance it's not going to falsely read high typically, unless you're, it's the middle of summer or something. And if it is, they're probably actually high. It may not just be an artificial reading. But if it's reading cool, I still feel like there's a chance that they could be running a temperature and you're just not picking it up because of the reliability of those. And then that brings me to the next question, which is, let's say we don't have like IV, the paracetamol or something to give them to control the temperature. And you are wanting to try to aggressively bring that temperature down. Let's just say it comes back and it says they're at 101 or 100. It's like a clear fever. And all you have in your ambulance is maybe room temperature IV fluids, ice packs. What would you do as a paramedic to try to get that temperature down? If you were going to write the guideline for a EMS service that you were the medical director for, what would that look like?
I think it's interesting to kind of have that difference of resources. Obviously, I think the important thing would be the goal being to err on the side of kind of like you're saying of cooling, of trying to do things to bring that core temp down. So often in critical care, from in all environments, we don't have all the data. Even like with the SWAN, everything else, I don't know what the hell is going on, and so we're left with picking interventions based off of their potential benefit and their potential risk, with sometimes very little evidence about what the situation actually is, but we could be pretty confident we know the risk benefit of stuff. So I think it's someone who has an active temp who isn't like didn't overdose on Tylenol. Something like IV paracetamol, IV acetaminophen is a great idea. And even you got to question things like NSAIDs at that point too. Any way to get the temp controlled. I think that's going to be pretty unorthodox given the likely risk of AKI and things like that. I was a resident in Las Vegas, and we saw a lot of hyperthermia, and then it'd be like these music festivals and the kids are out, kids they're
running man.
Up. Yeah, exactly. And so it's 100 degrees by 7 a.m. and they've been partying all night, and so we get these kids 108 degrees, and we had a lot of external cooling with fans. In the ICUs, those are typically a no-go for like infection control stuff. But if you could, ice packs in the groin, all that stuff. But also if there's any mechanism of applying moisture and then trying to evaporate that moisture, whether it is opening the windows or if there are fans, things like that. I think you maybe want to start getting creative depending on how hot it is outside, I guess. But
I say up here in Minnesota and Illinois, we just crack the window in the helicopter and we can bring down the ambient temperature pretty quick.
Yeah, because I think that stuff is important, and you can get a lot of bang for your buck with especially evaporative cooling. It can be really powerful. And then other pharmacologic things you can do, paralyzing a patient is likely to bring down any amount of their own thermogeneration, at least from musculoskeletal stuff. This gets a little dicey if you're really interested in a neural exam, but it's just, and I hope I don't get in trouble for saying this, the amount of times where a neural exam has mattered in that initial upfront situation is just very low. I mean, unless you're looking at a primary traumatic neural injury, that neural exam is just a lot less necessary. And you can find lots of situations where, exceptions to my really broad statement, but you can keep the temp controlled and keep the temp controlled. And we could always reverse, even rocuronium, which I don't think obfusing sucks in that situation. But we could always reverse rock. We can always reverse back at the hospital at that point if really somebody cares enough to do that neural exam that way.
Yeah. One of the things with EMS that I would worry about is you start putting those ice packs on, maybe in the groin, you crack a window, you give them some room temperature fluids, and the patient starts to develop like a shivering. They start to shiver a little bit. And that could be pretty detrimental too, because of the metabolism of shivering, and you're using up quite a bit of energy by doing that. And so when you look at the targeted temperature management and you look at the things that are associated with poor neurological outcome, it seems like running a fever and then also shivering, preventing them from shivering during that post-arrest period. And so I was looking at some of the different ways of preventing that. And it seems like ketamine, like a ketamine infusion, does a pretty good job. I saw quite a bit of references that talked about ketamine. What else can you do? Specifically for EMS, is there anything else? I know you want to stay away from benzos. You want to try to prevent that. And then you mentioned like paralyzing as maybe a last option if you can't.
Yeah, I mean, you've already got an airway, and so I think last option becomes, it's going to be a lot more effective than any sort of sedative. I mean, granted, like, we want to sedate our patients before we paralyze them, so there's that part of it. But I would argue if that's your main issue, my goal would be to sedate a patient to whatever comfort level or guidelines there are to facilitate paralysis at that point, as opposed to increasing your dose of sedatives to get an effect that the paralytic will do, because those sedatives are going to give us issues too. I mean, outside of an exam, is if someone does come in, if we're worried about seizure, well, if they had a bunch of benzos, like you're saying, we might not be able to actually get that data anymore on our continuous EEG. So I think sedating to the point of being comfortable with paralytics would be my perspective on how to control shivering. We use, I imagine you don't have a lot of buspirone, but magnesium, is what we'll often use too, is Buspar and mag. So, you don't know what the mag is. You probably don't want to induce hypermagnesemia, but that's just incredibly rare. And unless your patient had some really significant electrolyte issues to begin with, a couple of grams of magnesium is really unlikely to lead to some sort of toxicity in any sort of kind of a normal out of hospital state. So that might be an option as well.
Yeah, the topic of sedation is interesting. I was listening to a podcast with Josh Farkas and Adam Thomas, the IBSC podcast, and they were talking about staying away from benzos because of delirium. And obviously, if you're an EMS agency and that's all you have is benzos, then that's one thing. But not only the delirium, but also the delaying the neuro exam. And so, depending on how that neuro exam looks, I imagine coming from an EMS agency, like me transporting a patient, they're going to want to get an idea of what the neuro status is pretty quick. Whereas if they're in the ICU and you have to do this, they probably already have some sort of like neuro exam that they've had. And so I was curious because for us, like they were recommending like dexmedetomidine and propofol, and they're maybe already on a pressor. So you're going to kind of combat the vasodilatory that you get with propofol. And I feel like propofol is a decent option. I know a lot of people hate it because they say it's like hemodynamically unstable, but I feel like anything that's a sedative can be hemodynamically unstable. So if you had propofol running and you had like a Levophed infusion running, I feel like that would be fine, and maybe you're given a little bit of fentanyl, but they also mentioned like staying away from fentanyl just for the neuro exam. What are you seeing your patients, like the post-arrest, they're in the ICU, they're on Levophed or Epi or something like that. Is it pretty common to see them on propofol?
Yeah, I think that's probably our most common agent because it washes out pretty quickly. You get a lot of issues with benzos. I mean, they're pretty much a no-go. I think academic critical care has probably moved to a perspective. Maybe it's gone too far, but like benzo is a 4-letter word, and the residents, our residents don't even say those things anymore because it's the last few years been. This is a last resort kind of thing. Whether that's, has to be that way, I don't know, but that's definitely where I think the teaching is at this point. And propofol probably washes out the quickest. Outside of neuro exam, really it is continuous EEG as well, is one of the few things that we can actually do something about is if someone is statusing and the pre-hospital or pre-ICU sedation can mask that. And sometimes, I can easily conceive a situation where a spot EEG was done when someone still has residual benzos on board. Oh, it's negative, but then, we maybe miss what happens 6 hours later. We don't realize it till another day goes by and we're really febrile, or our lactic's really high, or something else makes us wonder about non-convulsive status. It's not that common, but of things you can reverse that look like anoxic brain damage, which is really the name of the game here, right? All we're trying to do is, the kidneys always recover, the liver gets better, the patient weans off pressors, everything is good, except they don't wake up is typically the experience, that sticks with you with these cases.
Sometimes in EMS, it's taught that if you're starting propofol and then you have to start levofed, that you're like fighting yourself and that you shouldn't be doing both of those if it's going to drop it. But in my experience, sometimes you have to, and sometimes propofol is the best option, and you put them on a sniff of levofed just to combat the vasodilatory response that you get from propofol. And I don't feel like that's like you're fighting yourself too much. I feel like that's like a typical thing I see in ICUs is they're on propofol and they put them on just a little sniff of levofed to combat that. Would you agree with that?
Yeah, I'd say that's very commonly used from the perspective, in the ICU. And I think conceptually, my branch point would be, do I have this shock state under control? Whatever it may be, if it's, post-arrest vasodilation, if we have ongoing MI with cardiogenic shock, like if I have that handled, and it might be, I'm sure it's easier for me to know that because I'll see my lactics clearing, maybe some urine output. So if I feel like that's under control, I wouldn't think twice about some degree of norepinephrine with escalating doses because of propofol. I guess the times I'd really consider those to be not conducive to work in tandem would be if I don't have control of the shock state, if I'm worried that, that I haven't achieved what I need from hemodynamics. But typically that, or not typically, often that does get handled, and you do have that space. And so I don't think there's anything wrong with being on 10 of levo or even adding vasopressin, and still using propofol in those situations, as long as I'm seeing my numbers going the right way, my lactic acid's clearing, maybe making some urine, and I'm pretty confident that I have control of the situation. Nothing wrong with that, I think.
Yeah. How do you feel about adding fentanyl? Is fentanyl kind of a no-go in the ICU, or is that pretty common?
It's like standard of care for anybody, I'd say, but people that are going to get extubated, the same day they were intubated, or in this situation. I think a little bit of fentanyl is probably not an issue. It does build up. And so if you are worried about ongoing neuro exams or about, EGs and things like that, you might run into some difficulty. Certainly brain death testing, which is a big part of this, you're not going to want to have been on fentanyl for some time. Mm-hmm. So if we're heading in that direction, it also makes you wonder what your goal of sedation is at that point. But also those are times I'd be staying away from fentanyl. Otherwise, everybody gets on a fentanyl drip pretty much once they're intubated from our practice pattern.
Because you're wanting to see if the brain's detecting that accumulation in CO2 and driving them to spontaneously breathe.
Yeah, exactly right. Yep. So it's and I when folks are cold, when folks have brain issues, it really is not a lot of sedative could make that difference. And whether that difference matters is like a totally philosophical discussion, and one that I think is an issue with so many of our cardiac arrest studies are European, and things are just a lot different there. There's way more bystander CPR, and I think their conception of a good outcome is honestly different than a lot of the patients that I have. I think we like to talk about neuro-intact survival as the only relevant survival, and I think that's true for a lot of us, and it makes sense. But my lived experience is not that at all, and I think a lot of families, it does make a difference if a patient is dead or able to survive even trach peg, or if they're trach peg unresponsive versus minimally responsive. Those things do end up making a difference for us in the ICU, and I think the studies we look at don't typically reflect that, which is another point of caution I have about some of those studies.
Yeah, so the paramedic or EMT or whoever's listening to this, and they're trying to figure out what are the takeaways, I would say that EMS probably unless you're doing an esophageal temp, rectal temp, bladder temp, if you have the ability to do that, that's great. But your little temporal scanners probably are going to be not as accurate. And so does that matter? Well, it depends, right? Because if you're getting a fever, if it's giving you a high reading, I would definitely trust it. But if you feel like that patient is running a fever and you're wondering, well, should I try to start to cool them down? Maybe some ice packs, maybe opening the window, maybe some room temperature fluids, but ideally prevent that shivering. You want to avoid the shivering, and then you're not routinely just saying, oh, you know what, I'm going to try to get this patient down and therapeutically like chill them down to like 32, 33, because the TTM2 showed that there's really no difference between the 32 and the 36. 36 seems logistically easier to do, just preventing them from running a fever. Would you agree with that?
Yeah, I definitely would. Yeah, TTM was 33, 36. Then TTM2 was 33 to like 37.8. So avoiding fever, and both of those showed us that 33 is really a very rare target at this point. It makes me wonder sometimes, like, you know, what some of the high profile things we see, what do some of these other places do, and when do you deviate from those norms? But I'd say really outside of exceptional circumstances, that 33 degrees is probably a historical thing at this point.
Awesome. Well, dude, thanks so much for coming on. I appreciate you letting us pick your brain.
Pleasure's always mine, man. Nice talking to you, and good to see you. Look forward to seeing how this turns out.
Oh, and real quick, you know, you don't agree with giving D50 for arrest, right? That seems.
It's interesting controversy to look into. It's again, a resource thing. Why the hell not? From my perspective, but I've got 20 nurses and a bunch of IDs, and I'm just standing in the back with my arms folded anyway. So
yeah, go ahead and give it. No, did you see Sam's blog?
Oh yeah, yes. I talked to him about it.
I thought he did a great job with that.
Yeah, it was like incredibly well researched to the point of I'm a little worried for him. The guy's going down some dark holes. He's got to pull himself out of that stuff. It's a spiral, a research spiral that you can.
That's a whole nother. That'll be a whole nother podcast. I think he was one to talk about that too.